Welcome to A Shot in the Arm podcast. I'm your host, Ben Plumley, and this is a podcast about innovation and equity in global health, because without equity, what is the point of innovation at all? Well, we've been here at the Kigali International AIDS Society conference. It's a scientific conference focused on innovations. And of course, there's been much attention on one particular long-acting antiretroviral. But of course, without communities, without patients, what is the point of having these new innovations? The same is true for research. If you want clinical trials, if you want clinical innovation, you have to have the involvement of both trial participants and the communities that they come from. Well, a key theme for activists at this conference has been making sure that the community voice is loud and being heard. And I'm absolutely thrilled that we are joined by friend of the pod, Solange Baptiste, who is the executive director of the International Treatment Preparedness Coalition, which is not the International Treatment Preparedness Coalition anymore. It is ITPC, as she reminded me last time. Solange, welcome back to the pod.
Thank you, Ben. Great to be here.
And aren't you impressed that I remembered to get the name right?
I am impressed.
And we're also joined for the first time by Rosemary Mburu, who is the executive director of WACI Health. Rosemary, welcome to the pod.
Thank you, Ben. Thank you for having me.
Oh, it's a real honor. Now, WACI Health, what does it stand for?
So it used to stand for, just like in the case of ITPC, World AIDS Campaign International. And then transitioned to WACI Health to enable us the flexibility to do more with global health space from our communities and civil society points of view.
Oh, great. Great. Well, one of those early transitions to the sort of broader integrated agenda. Brilliant.
Yep. Yeah.
Well, shall we talk this Kigali AIDS conference? What has the conference been like for you both, first up? How busy have you been? What is the vibe, the atmosphere? What's been going on?
Yeah, I can reflect on that because for me, even as I was coming to Kigali, one of the things I was very conscious about is how many colleagues, and partners couldn't be here this time because of the funding cuts and the crisis we are in and programs closing, and really just less of resources within our global health space than we had during the other IAS. And so just being here and conscious that as we are here, we are carrying the voices of so many other people who couldn't be here. So I think from a point of gratitude, there is that angle of just knowing you're here, but also knowing that the voice we brought here, the action we brought here is not just for us, it's just for so many other people who are holding the line. Mm-hmm. And I think that really has resonated with us, as communities and civil society throughout the conference on the need to really remind stakeholders, decision makers, scientists, on the value of communities, the value of civil society in HIV science.
Solange, for you?
Yeah, I fully agree with you, Rosemary. I think it's a privilege to be here, and we take the fact that we are here as a huge responsibility to speak on behalf of those who could not make it for whatever reason. I would say like three things resonate. I feel like there's always something about lenacapavir. There's something about prevention and what's going on in the prevention space. There's always something about AI, artificial intelligence, and then there's something about the cuts. What are we going to do? What's happening with the cuts? We could talk about those three buckets maybe, but to me, that's what I'm hearing bubbling up quite a lot. Yeah, it's been intense. It's science and research. So the room is, you can either go down a very deep bunny trail about, antibodies, or you can speak about cuts. I'm not so sure where we're landing.
Yeah. And just for the first time, going down the rabbit hole about antibodies is directly related to the cuts, because there's no guarantee that research is continuing to be funded. I mean, there's something interesting in what you both say about the cuts and community voices, because one of the things that I've picked up is this sense of, if we're being polite about it, prioritization. If we're being honest about it, we're talking about rationing of services. And that means that the nice to have community engagement, community leadership, service provision, oversight, keeping it real, as it were, all of those things really run the risk of being put to the back burner now. And I don't know how you both have advocated against that, and what strategies you think need to be adopted to make sure that the centrality of the community, which has been so important for the AIDS response over the last 20 years, how we maintain and defend that.
Yeah, so that's a very it's a very difficult time, obviously, and reprioritization, rationing of funding is especially difficult because you cannot say which community interventions are more important than others. So it's a trade-off, but it's a very painful trade-off because in an environment where you only have so much now, given the funding cuts, we also risk undermining certain interventions that are more important for, if you think about communities in all diversity, it becomes very difficult then to say this particular intervention is what is a priority. This particular intervention, can wait for another year or so. So it becomes very difficult, even at country level, especially where decisions are being made at country level. You realize that communities are now having to really engage with national governments. And so it's not just decisions among community interventions, it's now also communities having to come and make a case, to national governments about particular priorities that are important. And it becomes very difficult because you do not know really what to drop, what to pick, because community interventions are all important. And that's why we even talk about options in ensuring that communities can have a choice out of a pool of options. But also because community interventions are very evidence-based tools. So there is no way to argue against any. So I don't know. I really don't know, Ben.
It's not easy.
It's not easy. Solange, one of the things in this conversation that has really struck me, which I think is really important for us to make clear, is that NGO service delivery, which has been a central part of the AIDS response, and which, frankly, because of PEPFAR funding and somewhat of the Global Fund funding, has been a really important part of national programs. But now the microscope is on that, seeing the high cost of it compared to national service delivery. My point here is that I've been shocked to see that NGOs and communities are sort of interchangeable. People are thinking intellectually as if they are the same thing, and they absolutely aren't.
No, they absolutely aren't. And I think there's a certain level of expertise. One of the things that we're doing at this conference is wearing this white lab coat that says communities are experts. They bring a lived experience, but communities also bring data. And I think that's what Rosemary is talking about in making that argument about you have $1, where do we put the money? And so communities bringing the data to the table and bringing the solutions in a co-creative kind of co-architect partnership way with governments that hadn't happened before. There was always this middle broker that used to be in between the INGOs, the big PEPFAR funded groups, the PRs that kind of took airtime, took up the space. I think that space is now reduced, and you have communities now having a much closer relationship with their governments, making the case for what is. And yeah, I think the arguments now are more about cost effectiveness and what is just and fair directly to governments. So you have less money. What is the place where you put that money? And we can tell you where that is.
Yeah. And I think also to add on to that, there is every national HIV response has defined who the communities are within their context. And so it's very important that within that scope, we are careful to ensure that we are not just thinking about NGOs, we're also thinking about the community leadership. So community-led organizations, community-led approaches, and which actually is very important in terms of investing in that, because you are building systems. So community systems are very important. It's not just the product, it's not just accessing commodities, it's also about the future. It's also about the sustainability. And if we don't build the systems, the community systems, we don't strengthen that, then we don't have sustainability. Because today, Solange and I, we are here, we are leading these organizations, but the expertise we have, the expertise we transfer might not be there tomorrow if you actually don't have a system that can sustain that and can multiply this community expertise. So community leadership is very important, because that expertise lies with people and needs to be multiplied within that network. Even acknowledging that even when we talk about communities, even within the national HIV response, there are many typologies of communities. Even when we talk about key population, there are many typologies. And so just being conscious of that diversity, but also being innovative in saying, what is a mechanism that will help us to build a sustainable system that can advance community engagement and leadership?
Now, from what both of you said, it strikes me, and I don't know if you've thought about this, that there's actually an opportunity here. Because again, if we are clear with folks that community leadership is not international NGO leadership, with the departure of these large international NGOs and the budgets that they take up and the sort of parallel systems that they operate compared to national programs themselves, there is an opportunity for community leaders to do precisely what you're saying. We can help you work out what is cost effective, what gets results. We can be your partners, we can also be your challengers, but we are absolutely part of the sustainable system. Have you seen opportunities emerging for that kind of conversation to take place, or is it still a bit pie in the sky?
I mean, I would say that there have been opportunities, and it's sort of not opportunities that will just say, here I am, I'm an opportunity. You have to kind of go seek them out, especially in the AI space. So the common narrative is AI is North America or even China. There's this big data, they take over things. And a question came up in the AI and HIV vaccine research and development, whether or not this kind of capacity to lead this charge and to do this work actually exists in Africa. And there was a resounding yes in the room. So the capacity exists within Africa and within the communities, and it may not be the very specialized, from a community perspective, very, very, very specialized in the vaccine development, but they're certainly going to be part of the conversation. So I think there is an opportunity for all of our expertise to be showcased.
No, there's no question about capacity. Capacity is there, absolutely. And I think that you have local, and when I say local, like African or organizations, NGOs, community networks in the global south, if you take Africa, for example, that can actually lead and are leading actually. And I think it would be tragic if we were saying there is no capacity, because like what happened with all this investment into capacity, strengthening capacity, this, capacity, that. No, capacity is there. And so I think this has to be part of the conversation around reimagining the global health architecture in terms of what exactly are we looking for when we talk about leadership, when we talk about leadership from this, what is missing really, but also how do we as a global community within the global health space enable, facilitate that leadership? Is it the way funding is done? Is it the way accountability is done? What is that pathway that actually will get us to trust? I think it's also an issue of trust. Will get us to trust local leadership, but capacity is there.
Well, you mentioned global health architecture. So let's go there for a minute.
Yeah.
The two institutions of the global health infrastructure that really haven't been very present in these conversations at the conference are, of course, UNAIDS, which has gone through its own challenges in recent months over budget cuts, and of course the Global Fund. But kicking off with UNAIDS first of all, do you think it was a bit of an own goal that they weren't here, or does it not matter given that this is primarily a scientific conference?
Wow, Ben. Don't know. I mean, I think it is what it is. I think the fact that they're not here signals to me that they're having to make tough decisions. Is the best use of the limited funds that we have at UNAIDS to attend this conference, is the use of Winnie and UNAIDS director to go somewhere else? What is the best use of their time and resources? I don't know if it signals anything more than that. I think that the UNAIDS data is clear. There are other people here. Mary Mahi's here from UNAIDS, and there are a few data sessions that she was in. We have the targets, we have the strategy that's ongoing. So there is work that UNAIDS is still doing. So I don't think that their huge contingency of presence doesn't signal to me. It signals to me a little bit of common sense. That's just my opinion.
I also saw it as an element of saying the response is in safe hands. I mean, communities, partners, and also it's definitely a difficult time, especially for the UN community, just thinking about budgets and prioritizing. But I think I'm really aligned with Solange's point of view in terms of the data is there. The country leadership, was here from the UNAIDS perspective, and the partners were here, the scientists were here, communities were here, and many UNAIDS colleagues, including senior leadership, deputy directors, joined sessions virtually.
Yes.
So we saw that support, we saw that presence.
So then the other group that we haven't spoken about very much at this conference, and this is concerning given that it's, apart from PEPFAR, the main column of funding for the global AIDS response, is of course the Global Fund. And I don't know whether it has been expressly intentional, but there's certainly been, I think, a passive intentionality of sort of staying below the radar, focusing on this upcoming replenishment. And Rosemary, I don't know what your sense of what to expect with the Global Fund this year. It just feels very odd that they're not part of the conversation at the moment.
So I'm obviously biased on this one because as WACI Health, we host the Global Fund Advocates Network. So this is a community of advocates who champion for Global Fund resource mobilization. And so we're also very much aware of the similar challenges, like with the UN community about the funding, but also the sensitivities around this replenishment. Many times we have had to be very tactical in terms of when you say what, where you get to be loud, where you have to be a bit quiet and calm and soft. So it's been a lot of navigating, especially because you really have to make sure that the geopolitics as they are playing out right now do not in any way impact the outcome of this replenishment. And there's really no way to tell which direction that fluidity will go. But of course, there were some Global Fund staff here. Marike was here. Dr. Vu Iseka was here. And there was also a side meeting focusing on the 8th replenishment of the Global Fund. I had the opportunity to speak at the opening ceremony. And one of the things I was speaking about was just reminding the world about the funding cuts and really saying that we cannot go in that direction, because if we did, it will take us back to the days before the Global Fund and before PEPFAR. And so we must move forward. And I was also reflecting on the fact that this replenishment of the Global Fund could be a lifeline for communities, because right now we are talking about, countries organizing around Grand Cycle 7, even as we anticipate Grand Cycle 8. Mm-hmm. And so if the Global Fund replenishment is not successful, that will be another problem to deal with again. So it is more now than ever very important that we are successful in the aid replenishment of the Global Fund.
So can you help me out understanding one thing that I apologize is not particularly clear to me? We know that the US has dedicated funding for the Global Fund, at least for next year, for the next financial year. Is that less or the same as was expected? And, there's also a sort of an equation, an algorithm that goes with US funding, that it can only be, I think, no more than 30% of total investments that come into the Global Fund. Are we on track for that, or is it still a bit opaque?
So I think what I would say to that is that we are still, for me, and I know many Global Fund advocates, champions in the region here, we are still catching up on understanding the US contribution or pledge. But what we know is that it's a good thing coming out of Washington. So I think where we were a couple of months ago, we felt like it could totally collapse, And so hearing some good news, even though we don't necessarily have clarity in terms of like how much exactly then is it that we will get from the US, and maybe our counterpart advocates in the US have more clarity around that. What I know is that just hearing these news, even as we try to figure out what the figures are, is some good news. Yeah, because nobody knew how it was going to shape. Yeah.
Well, it sort of gets us to the broader fiscal space question, doesn't it? And Solange, we're recording this on the penultimate day of the conference on Wednesday, the 16th of July. And we've had some extraordinary news from the US. One, that it looks like the US Senate and hopefully the House of Representatives will put $400 million of PEPFAR funding back into the budget for this year, I guess. But then there have also been these most extraordinary allegations that, and extraordinary actually is being too polite about it, but the idea that PEPFAR money has been used to train Russian women on how to conduct abortions. Where do you get this from? So, which of course is just plainly not true, just factually inaccurate. So, I hope you don't mind my asking what the bloody buggery bollocks is going on.
Why did I get this question?
You get that. You get that.
All right. First, I would want to just pick up on the lifeline. I do want to agree with Rosemary's point that the Global Fund will be a lifeline, because I think no matter how hopeful, and I do think it's a positive sign, at least, that across the aisles in the US, that there is a signal that says this PEPFAR is important. And so the money coming back, at least that is positive. We have to look for all the silver linings that we can find. But what we are not sure of is what is that going to mean? How is that money going to be allocated? What are the conditionalities of that money? And if we take the waiver as a signal, there are certainly going to be conditions around key populations, prevention, and community-led services and interventions. So that's a concern that we need to keep our eye on. The other thing I would worry about or want to make sure is that our African governments or governments across the globe who were receiving PEPFAR funding, now there was fire under their feet saying there's no money, we don't know what they're going to come with. And so we need to figure out resource mobilization at a national level domestically. This is not the time to ease off. Oh, the money is back, we are fine. So this cannot be the signal to the governments that as communities will keep putting that pressure saying, where's the fiscal space? You need to take care of your own citizens. Let's make a plan. So I think that is what that is. This nonsense about the Russians and the what, I think it's honestly scared people in the US picking up their phone and calling up their representatives, saying something. And, people speak their little whispers in the wind about how those things then trickle back up and say, here we are funding abortions to, it's just different things that you hear, but it's not really founded on any actual evidence and what the truth is. So we want to squash those and let's focus back on the science and see how best to allocate this funding.
I'm not always the greatest fan of the New York Times, but I do think the reporting on this has been as acerbic and as clear as you could possibly be. The press officer of the Office of Budget Management, or the management of the budget, OMB, was challenged. Okay, where do you get this from? Where was this taken from? And she couldn't answer it. And so it's really clear that this is just, if you're being polite about it, factually inaccurate or misleading. And if you're being really honest about it, a lie. Well, we've come through about 3/4 of the podcast and we haven't spoken about the science that's happening at this conference. And so if we put lenacapavir to one side, innovation, groundbreaking change that it portends and could be, has there been anything else that has stood out to you as something of interest, something that viewers and listeners of A Shot in the Arm should keep their eye on?
I think it's mostly been long-acting PrEP has really been the latest breakthrough, and that's the latest science, lenacapavir. So from a science point of view, we see that, we stand in a time of great promise. But of course, there's a lot to that science that we've been interrogating, because we've been talking about issues around access. So you have the science and lenacapavir. I think it's what we have heard about, loudest. But in terms of access, we are also saying that the prices need to come down. Because the science is there, but if governments cannot procure that for people who need that, then it can be very difficult. But we're also saying that it's important for national governments to prioritize the interventions that are coming up, like LEN, and I'm a choice advocate. I advocate for choice because I believe that the needs are different. They are diverse. There's someone who doesn't want a shot in the arm.
Except here.
Except here. And unless you're having the cabotegravir injection, which is...
There. You see, that's also choice. That is also choice. Yeah. And some people will prefer the pill. Some women will prefer the vaginal ring. And so on and so forth. And so I believe in choice, and it's exciting to see this whole range of options. But for us to translate that into choice, we have to invest in that so that people can access them. And affordability is very important, when it comes to that. National level prioritization in terms of making sure that we are updating our national guidelines. I mean, WHO did an announcement about their new guidelines for LEN. And so it's now to countries to look at that, whether they want to update their guidelines to align to that, so that then they can roll out LEN and the other things, the pill, the injection, the ring, all of them. Yeah. And so I think from a science point of view, there has been really good movement. The other thing I heard here, which I haven't heard before, I hadn't paid too much attention, is around advanced HIV disease. Maybe you've heard a bit about it, because we have been saying that U equals U is now a lived reality. We have known that, of course, children are disproportionately left behind when it comes to treatment outcomes. And so for children, U equals U, we are still very far. But what I'm learning with the advanced HIV disease is that we are struggling also with adherence and progression of disease in many places around the world. And so today this week there has been quite a number of side sessions and quite a bit of a buzz to raise the flag and to, bring out the alarm to say, this is coming up and we need to watch this, which I think is important because we've I think believed that for a long time, we've believed like people are not dying anymore. I think that has been the narrative. But what I'm hearing more and more is that no, people actually are dying, where U equals U isn't happening. And so I know GNP Plus, AfroCab, UNITAID are leading on some work around that. And I think that's going to be an interesting space to watch. Yeah.
And a lot of that work has to do with access to viral load testing.
Yeah.
So you don't know where you are and you lose you if you cannot figure out your viral load, right?
Sure.
And so I think this point about access and affordability is really critical.
Yeah.
And it, as you said, who isn't a proponent of choice in this space?
Yeah.
But that is sort of an illusion if you don't have the treatment education, the prevention education that can really make you have an informed choice.
Yeah.
And I think there's a little bit of confusion as well when we have these 9 countries that the Global Fund says they're going to fund for lenacapavir, and you have countries that still have CAB for PrEP. And so there's no clinical data on your switch from CAB to Len. We don't know if you can just switch. What will be, in the body, what those two things do together.
Yeah.
So there's still a gap in the understanding, and there's still a gap in the sort of treatment and prevention education spaces that we have underinvested in. So I fully support that. And I think just to add the long-acting technologies also for treatment. I think that is also something we need to keep our eye on, not just prevention. It has, again, choice and the options that we still need to get those things through the pipeline.
Yeah.
Well, I think we've pretty much covered everything that was on my short list for this conversation. Is there anything we've missed? Anything that you think is really important to flag up at this point?
I think there are maybe one or two things that I would say. One is around this integration. So in the cuts, now everybody has less money. We need everything to come together. And integration has been an interesting, we've been trying to integrate TB and HIV since Moses was a baby. So here we are. We're still now trying to integrate HIV into a very fragile public health system. So what is this going to look like? And just from a data perspective, I think it's important to think about, not just interoperability and how the systems will speak to each other, but what are we solving for? Are we solving for data and tidy spreadsheets, or are we solving for lives and for perspectives and for people? So when this data comes together, I feel like we want the data to be intelligent. We want the data to tell us what is the place to put the allocation, right? So this data should be intelligent, but the data without the people is just a bunch of noise. We need to have the people as part of it. So I don't care how much digital response, how much AI you have, make sure that it's people-centered. I think that's the one thing, because there's a lot of conversation around monitoring and systems coming together. And the second piece I would say is just around efficiencies. So we are talking hell hard about efficiency, the importance of even cost efficiencies in systems. We need to find the most efficient way. But it can also ignore justice. So you pick up a different tool if you are looking for efficiencies. But if you are really looking for justice, as you said, pediatric HIV is on the back burner. Small volumes, you hear this conversation all the time. That's a justice-oriented lens. You need to say, no, this is the right thing to do. And even if the market is not saying that, we need to still pursue that as science and research. And so we need to make sure that we keep our feet on the ground and keep pushing, as I think Yvette said at the beginning.
Yes.
There's no science without the people.
Without the people. And I think for me, my last reflection is you can see how many things we have to resolve. Like how many spending things, like there's a lot of work to be done. And so there has been a notion that, we are done with HIV, we are almost through. And you can see that deprioritization even from a funding commitment point of view. We're also conscious that global health itself has been deprioritized. And so I think for me is to say, if we deprioritize global health, if we deprioritize HIV, you can see the impact. You can definitely see the impact. We have seen the impact, and we still don't know what the impact is fully, really, of the funding cuts. And we will know that with time. But like for me, it's just a call to say there's so much that is coming out that still needs to be worked on, that still needs funding, that we still need to work for access, for equity, for data to understand. And we are not done. We are not done. And so we need to still continue to put global health and HIV really top on the political agenda.
Well, Rosemary, what a wonderful call out to end this episode. And Solange, thank you as well. This has been a really powerful conversation, and I think really keeps our feet to the fire. So thank you so much. Well, that is it for this episode. Thank you again to Rosemary and to Solange. Thanks also to our production team here in, where are we? We are in Kigali. Thank you. Oh, you can tell it's coming to the end of a long day. We are in Kigali, so thank you to our production team here, headed up, as always, by our fantastic and persevering director and producer, Erica Spera of Newstalk Media. And finally, a big thanks to you. Of course, you know what to do. Subscribe and like wherever you download your audio podcasts, and visit us on our YouTube channel at www.youtube.com/@ShotArmPodcast. Subscribe, like, and smash that notification button so that you'll get headlines of when fantastic episodes like this one go live. So with that, have a great week and a safe week, everyone.